Mr. Chairman, ladies and gentlemen, first I want to acknowledge that I received financial support from the Karolinska Institute, the Stockholm County, and the Swedish Heart Lung Association, and I'm a shareholder of Cardia Innovation that owns the patent for CO2, for the CO2 gas diffuser carbonate and the patent's use of CO2 as an antibiotic drug in open surgery. I will talk about the consequences of exposing internal tissues to ambient air and the advantages with CO2 insufflation in the operating field. The skin is a barrier against ambient air. Ambient air in the OR can be contaminated. It's lower in temperature than the body and has a low relative humidity. Exposing the surgical wound cavity to ambient air can cause, as we heard earlier, entrapping in the heart in open heart surgery and thus lead to arterial air embolization. It can increase the risk of surgical site infection through direct airborne contamination by cooling, which you get by evaporation and radiation, and cooling will cause hyperperfusion. And finally, ambient air can lead to desiccation of exposed tissues by water evaporation, and this can promote the formation of postoperative adhesions. Traditional de-airing of entrapped air in the heart is ineffective. As we heard earlier, air will be gathered in the most superior parts of each cavity. And large amounts of microemboli are detected in the brain during weaning from CPB. Despite traditional de-airing, air emboli occur more than 30 minutes after CPB with traditional de-airing. And the Trendelenburg maneuver is ineffective, and so is TE-guided surgical maneuvers. Carbon dioxide is heavier than air and has a much higher solubility. It's 150 times more soluble than oxygen and 25 times more soluble than nitrogen. Effective CO2 de-airing requires an effective device to insufflate CO2 with a low flow velocity so that you have a laminar flow. Otherwise, if you have a jet, you get turbulence and high air content in the cavity. And the device has to stay efficient even when it gets wet. You need a high CO2 flow to compensate for diffusion, the suction devices, and the surgical movements in the cardiothoracic cavity. And the insufflation should be within the cavity and start before opening and continue until closure of the heart and the great vessels. We did a randomized clinical trial involving 20 patients some years ago. We randomized them to a control group or to CO2 insufflation with the gas diffuser. And we looked at the number of microemboli with TE. Here's a control patient. Here's a patient with CO2 after bypass. And the number of microemboli were fewer with CO2 and disappeared earlier with CO2. Here's after declamping, big difference. Here's at end of bypass, before end, after end. And as you can see, the number of microemboli in the CO2 group disappear much quicker, indicating that these microemboli contain CO2 and not air. And the indication for de-airing with continuous CO2 insufflation is valve surgery, or when the heart is open, aortic surgery, single clamp coronary surgery, where you get an opening into the heart or left ventricle. And if you want to avoid air emboli, like when you use vacuum-assisted venous drainage, or when you insert an ECMO through a stenotomy, where you don't want to have any air into the circuit. Now, surgical site infections are rather uncommon in cardiac surgery, but they will cause an increased mortality, increased hospital stay, and increased costs. And Staphylococcus aureus is one of the main culprits. It's part of the skin flora, and it's spread by airborne particles from the skin, and the operating staff is usually the source. And a few years ago, there was an editorial in New England Journal of Medicine where they listed the major factors that have been proven to influence the incidence of post-operative wound infections. Type and complexity of surgery, the underlying disease of the patients, absence of prophylactic antibiotics, hypothermia during surgery, intraoperative hypovolemia, low tissue oxygen tension, presence of bacteria in the wound, and inadequate post-operative pain control. These 2 factors you can't do anything about. These 5 factors are intraoperative factors, and you have to secure adequate post-operative pain control. So the main message, this happens intraoperatively. And for this reason, in the OR, we usually have a ventilating system to decrease airborne contamination. You have an ultra-clean air source, and you have a high flow at a low flow velocity of laminar flow going towards the patient. However, an airflow that is directed downwards might actually increase contamination of the surgical wound. And the airborne contamination increases 27 times when the surgeon leaves forward above the surgical wound. The same happens during a snowstorm. The snowdrift will build up behind the obstacle because you have turbulence and stagnation behind the obstacle. And here you have the laminar flow coming from the roof. These are the obstacles. These are the sources of bacteria. You get turbulence, stagnation, and bacteria into the surgical wound. So shouldn't the flow be directed the other way around and originate from the wound? And we asked ourselves, can insufflation of the surgical wound with CO2 decrease direct airborne wound contamination? And this is an example showing that an upward laminar flow will repel airborne particles like those from cigarette smoke. With this upward laminar flow, all the particles drift away from the cavity. And in another experiment, we had a cavity the size of a cardiothoracic cavity, 2 agar plates. We had either a gas diffuser delivering a laminar flow or an open-ended tube delivering a jet and causing turbulence. And we could show that the upward laminar flow of CO2 decreases airborne contamination. Here's the colonizing forming unit count. This is the control during a 3 hours experiment in a cardiothoracic environment, in an operating environment. And here, if you used an open-ended tube, you got the turbulence and you got more CFUs. Whereas if you used a laminar flow, insufflating the cavity and got an upward flow, you could reduce the number of CFUs. And in fact, if this was with 5 liters per minute, if you had a higher flow of 10 liters per minute, you could reduce that number with 80%. And in another experiment, we did a sham operation. We looked at the air count in a surgical wound area. We could measure the airborne particles per square or cubic feet. Here, the surgeons were standing next to the OR table, not performing an operation. There were no particles in the wound area. Whereas when they bent forward and performed the operation or the sham operation, you had a high increase in airborne particles. And if you had a wound cavity and insufflated that wound cavity during this sham operation, you could decrease the number of particles in the wound area. Now CO2 is used for food storage. This is an example of minced meat, and if you read carefully, it's packed in a protective atmosphere, and that protective atmosphere contains CO2 because CO2 inhibits bacterial growth. And we did a study where we looked at the effect of CO2 at body temperature, and during a 24-hour time period we looked at Staphylococcus aureus, and we could see that if these bacteria were stored in air, you had a 1,000-fold increase in the number of bacteria. If it was stored in nitrogen, an anaerobic gas, there was a 100-fold increase in bacteria. But if you stored it in CO2, there was no increase in number of bacteria, indicating a specific effect, bacteriostatic effect of CO2. And in another study, we had a broth with bacteria, and instead of counting the number of bacteria, we looked at the optical density of that broth. The more bacteria, the higher the optical density. And we bubbled the broth with air and saw a logarithmic rise in the optical density. Whereas when we bubbled the broth with CO2, there was no increase in optical density, which means no increase in number of bacteria. And there was a statistical difference already after 2 hours between the two groups. During open surgery, you get evaporation. That would cause desiccation of the internal tissues. And that the desiccation starts immediately you open up the tissues. They open up the skin. And the determining factors are convection, humidity of the ambient air, and the duration of exposure. And that might at least part explain why we get a pericardial or a peritoneal injury, and part explain why we get postoperative adhesions. Evaporation will cause cooling, and cooling will cause vasoconstriction, a decreased perfusion, a decreased local tissue oxygen saturation, and thus increase the risk of surgical site infection. And it's been shown in a study some 10 years ago in colon surgery that if you had a body temperature if you lowered the body temperature 1.5 degrees Celsius compared to a warm patient group, you increase the rate of surgical site infection. And can wound desiccation be averted during cardiac surgery? Again, we did this experiment. We had a cavity, 2 agar plates. Remember that agar contains 95% water. We either insufflated the cavity with CO2 through a gas diffuser, giving laminar flow, or an open-ended tube giving a jet and thus caused turbulence. And we looked at the desiccation rate, which is the water loss rate in milligram per square centimeter times minute. This is the control. When we used an open-ended tube, there was turbulence, and thus we got a higher desiccation rate. And with dry CO2, there was no significant difference versus the control. Whereas when we used humidified CO2, we could almost avert desiccation. Can CO2 warm an open surgical wound? Well, as you may know, or you should know, CO2 and water vapor are major greenhouse gases. They have an insulating effect. So humidified CO2 will prevent evaporation, reflect radiant heat, but can it warm the open surgical wound and thus possibly decrease the risk of surgical site infection? Again, an experiment. We had a water container at 37 degrees. We had a cavity. We had a gas diffuser. We had two agar plates where we looked at the surface temperature. So this was a wound model. And what happened, this is the control. When we insufflated that cavity with air, there was no difference in surface temperature of this wound model, whereas we insufflated with CO2, there was an increase in surface temperature, and the highest values were reached with humidified CO2. And what about patients? These are infrared pictures from a cardiothoracic wound. Dark means 25 degrees. White means 37 degrees Celsius. So you can see that the wound edges are cold, hypoperfused, and also the right ventricular outflow tract is colder, indicating that you have evaporation and cooling of that area. But if you insufflate the wound cavity with humidified CO2, the wound edges are much warmer, and so is the right ventricular outflow tract. So wound insufflation with CO2 may reduce the risk of post-op surgical infection, since it reduces airborne contamination. CO2 is a bacteriostatic drug. CO2 increases wound tissue oxygen tension, since it warms up the wound. You have the greenhouse effect. It will prevent desiccation. You get the direct vasodilating effect from CO2, and you have the Bohr effect, the rightward shift of the oxygen saturation curve, so that more oxygen will leave the hemoglobin molecule. So in conclusion, CO2 insufflation in the operating field with the high laminar flow may help to prevent arterial embolism, surgical site infection, and post-operative adhesions. Thank you.
Thank you very much for a very nice presentation. Are there any questions from the floor? Yes, please.
Use the microphone, please. The microphone.
Good afternoon. Do you have an experience of use of this method in the pediatric?
Can you speak up, please?
Pediatric cardiosurgery. Do you have an experience of use of this method?
I haven't a personal experience, but there are some centers using that in open heart surgery for pediatric, for kids.
And the second question, if the differences of effectiveness of this method referring the volume of the operating field.
The size of the cavity?
Yes. Size of the cavity.
If you have a smaller size, you don't need such a high flow. So the flows that we recommend for adults is 10 liters. The smaller the size, the lower the flow you can have. It depends on if you think about repelling bacteria falling into the cavity, it depends on the size of the cavity, the area, the entrance area of the cavity.
Thank you.
I have one comment to make. That a flow of 10 liters per minute with CO2 will lead to a dramatic increase in pCO2 measured in the blood. So your oxygenator needs to be, the gas flow in the oxygenator needs to be turned up in order to eliminate the CO2. So there can be a problem with borderline size of an oxygenator in pediatric, for example. If you have a certain flow range and you have an oxygenator that has a limited capacity and you increase CO2 flow, you may not be able to eliminate it. So that's something to think ahead of if you're using this technique.
But I will comment on that. You should think even further. You should tell your assistant not to suck CO2 from the cavity into the cardiothoracic reservoir. Only suck blood, and otherwise turn off the suction, and then you don't have a problem.
I agree.
There was one more question? No. I also have a question. There's this idea about where to place the diffuser. Some people put it in one edge of the cavity, others put it deeper down. Other people, at the end of the procedure, put the CO2 directly into the heart. Do you have any suggestions? What do you think is most efficient?
I think, first of all, you have to start before opening, because once you open the heart, CO2 should get into the heart and not air, because air is then otherwise very tricky to get out by trying to insufflate it for a short time because of the trabecles in the heart. And then I think we have shown in a few studies that you have to insufflate it within the cavity, and we recommend it to be like 4 or 5 centimeters into the cavity. And if you have it's up to the surgeon to decide where to put it actually. If he feels comfortable to have it in one position, that's up to him, I think. We recommend it to put it close to the diaphragm because the surgical activity there is not as high as